All right, we're back with another video number two in this asthma series. This video is going to focus on key clinical activities for quality asthma care. And basically, we're just going to get into, activities, action steps, asthma diagnosis, long-term management of asthma control. We're also going to look at exercise-induced bronchospasms, talk about that a little bit. And then also we're going to get into asthma control for pregnant, almost said people, pregnant women, and how to manage that. And then we'll see how it is to manage exacerbations as well. All right. All right. So an asthma diagnosis determines that symptoms of recurrent airway obstruction are present based on history and exam. So, when you got the history of all these symptoms, cough, weak, recurrent wheezing, difficulty breathing, chest tightness, whether it's at night, with exercise, viral infection, exposure to something you're allergic to or it's irritant, changes in the weather, hard laughing, crying, stress, all kinds of factors, right? Patients 5 years or older are going to be able to use spirometry to determine that airway obstruction is at least partially reversible. And then consider other causes of obstruction that might not be asthma. So that's asthma diagnosis. This is long-term asthma management. So the goal is asthma control. We want to reduce the impairment, prevent those chronic symptoms, and less use of those SABAs. You want to maintain normal lung function and activities. And then, like I said in the video before, reducing the impairment, and then now we're going to reduce the risk, prevent those exacerbations, and limit hospitalizations, preventing that loss of function, lung function, and then minimizing adverse effects of the therapy. So this is long-term management. All right, so how do we assess and monitor? We're at each visit, you're going to assess everything: asthma control, proper technique on inhaler. There was this lady at the PFT clinical today. She showed us how she uses her inhaler, and she pushes it and puts it in front, and it go not in her mouth. And then she like grabs it with her mouth. It was really fascinating to hear. So not everybody, even though as simple as it may sound, not everybody understands the technique. So being able to make sure the patients are doing it right is definitely very important. And then, like I said, that written asthma plan, it's very important, especially for our home care patients that are, don't have that ability to get to the hospital really quick, really rural areas or what have you. And then, plan, patient adherence, and patient concerns. It's all teamwork and making sure patients doing what they're supposed to do, and then our healthcare providers are doing what they're supposed to do by just managing their asthma control. Obtain lung function measured by spirometry at least every 1 to 2 years, more frequently for asthma that is not well controlled. So if you, like I said, those patients that are having daily problems, they're definitely going to need more than one spirometry every couple of years. And then determine if anything should be adjusted. Should we maintain our treatment, step up, or step down if possible, if it is well controlled? All right. Another big factor is using those medications, selecting the meds and delivery devices that meet the patient's need and circumstances, using a stepwise approach that the panel report really went in detail about to identify appropriate treatment options. And then looking at that, the ICS and inhaled corticosteroids are the most effective long-term control therapy. But you got to consider the relevant to the patient, like risk impairments, the history, the response to the medications, and the willingness and ability to use medications. You got to review the medications, technique, and adherence at each follow-up visit. So it's a very, very detailed step by step for our patients. All right, now we're going to get into asthma care for the exercise-induced bronchospasm. I used to coach high school soccer, and I've seen it one time, and if you're not used to, well, I mean, nobody's used to it, but it can be scary. Like somebody's on the field and they just start bronchospasming out of nowhere. It can be pretty scary. But anyways, physical activity should always be encouraged. Teach patients to take treatment before exercise, and the short-acting bronchodilator will prevent exercise-induced bronchospasm in most patients. But also, our leukotrienes and then our long-acting bronchodilators are protective. And frequent or chronic use of those LABAs to prevent exercise-induced bronchospasm is discouraged because it'll disguise it. You may think your asthma is pretty controlled, but it's really not. And then exercise-induced bronchospasm is often a marker of inadequate asthma control and responds well to regular anti-inflammatory therapy. So I guess this goes back to, going back to those visits, those follow-up visits, looking at your patient adherence, looking at medications, and looking at each episode. When is it happening? How often? So we can adjust. Do we need to step up or maintain? And then encourage a warm-up period or mask or scarf over the mouth for cold-induced exercise induced bronchospasms that would help patients as well. All right, now for pregnant women, not people. So asthma care, pretty much with pregnant women, you just want to manage their asthma by any means. So we're going to check their asthma control at all prenatal visits. It can worsen or improve during the pregnancy. So we got to adjust those medications as needed. Treat asthma with medications is safer for the mother and the fetus than having poorly controlled asthma. And maintaining that lung function is important to ensure that oxygen supply is going to that fetus. Like I said before, those ICS are the preferred long-term control meds. And then just to remind patients to avoid exposure to that smoke. It's not good for us. All right, and now managing exacerbations. We're going to talk about two different settings. First, we're going to get into home care. So the biggest, most important thing here, I think, is developing that written asthma plan. So when something happens, your relatives, your caretakers, whoever it may be that's going to be around will kind of know what to do and be able to spring into action. So you want to teach the patient how to recognize those early symptoms and PEF measures that indicate worsening asthma. Adjust the medication, so you might have to increase the SABA or in some cases add that oral system corticosteroid. Remove or withdraw from those environmental factors contributing to exacerbations. It could be something inside the house, something outside. Monitor response, and then seeking that medical care if there is a serious deterioration. A lack of response to treatment, give specific instructions on who and when to call. All right, so that's at home where it's more independent based and you're more relying on family members and yourself to kind of know what to do. Now, in urgent care at the hospital, or if you need the urgent care from the hospital, we're going to assess severity by lung function measures. So basically for ages 5 and up, and the physical exam and signs and symptoms. We're going to treat to relieve that hypoxemia and airflow obstruction, reducing airway inflammation. So first and foremost, a supplemental oxygen just to correct that hypoxemia. That's first and foremost. And then we're going to get into, treating with that dual neb for for just to really, really help those severe exacerbation symptoms go down. And then if the patient that does fail to respond to that, dual neb or SABA, that systemic corticosteroids in moderate and severe exacerbation may help. And then we're going to consider adjunctive treatments such as IV magnesium or Heliox in severe exacerbations when nothing else is working, pretty much. All right, so this pretty much wraps up video number 2. Thank you, and I'm gonna stop recording.